Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Shahad, your host for today's episode, and I'm joined by Yomna to talk all about anemias.
Hello, Shahad. I have been looking forward to this episode for forever. And from its name, anemia can be broken down into an, meaning without, and hemia, which is the Greek word for blood. And while a human without blood would be a dead human, its name gives us a hint as to what we're dealing with.
And I'm sure there's way more to it than just the classic iron deficiency anemia we've all heard of. So, before diving into the different types, let's build a solid foundation, starting with what anemia actually is and how we classify it.
So, anemia is basically a reduction below normal in hemoglobin concentration, red blood cell count, or hematocrit. It basically means that the blood's oxygen carrying capacity has dropped.
So, our key parameters are hemoglobin, hematocrit, and RBC count. Let's talk about each of them one by one.
So, HB or hemoglobin measures the concentration of, surprise, hemoglobin in the blood. The normal range is about 13 to 18 grams per deciliters for males and 12 to 16 grams per deciliters for females. Anything below that, and we would have anemia. Hematocrit, also called the packed cell volume, represents a percentage of blood volume occupied by red cells. Normal values would be around 40 to 52% in males and 35 to 47% in females. And last, but certainly not least, we have the RBC count, which is simply the total number of red cells per liter of blood. Roughly, it is around 4.5 to 6 million per microliter in males and slightly lower in females.
Now, let's put our Nancy Drew caps on because the real detective work starts here. So, when we look at the red cell indices, things like MCV, MCH, MCHC, and RDW, what do these tell us?
Good grief, Shahad, that is a lot of letters. Let's break it down. So the red cell indices help us figure out why the patient is anemic by describing the RBCs themselves. To begin, we have the MCV, also known as the mean corpuscular volume, and this measures the average size of red cells. A normal MCV is anywhere between 80 to 100 femtoliters. If it's below 80, we would have a microcytic anemia, small cells. Anything over 100, and we would have a macrocytic anemia, bigger cells. Moving on to the MCH, also known as the mean corpuscular hemoglobin, and it is the amount of hemoglobin per cell. It'll help us describe whether the cells are hypochromic, hypo less than, chromic referring to color, so pale cells, or normochromic. And if you notice, I didn't mention a thing called hyperchromic, because cells can't really overfill with hemoglobin, otherwise they just explode. MCHC, or the mean corpuscular hemoglobin concentration, measures the concentration of hemoglobin within each red cell. It is especially important in conditions like hereditary spherocytosis, where the MCHC is actually elevated due to cellular dehydration. RDW, or the red cell distribution width, tells us how variable the cell sizes are, basically how much anisocytosis there is. A high RDW means you have a variety of cells of many different sizes, which is common in iron deficiency anemia, while a normal RDW will suggest something like a thalassemia trait.
Okay, so to sum it all up, MCV gives us size, MCH or MCHC tells us color, and RDW tells us uniformity. That sounds like the perfect trio for classifying anemias.
Truly the three musketeers. And usually we can classify anemias into two main ways, by morphology and by underlying mechanism.
Let's start with the morphological one, since that's what we often see in lab reports.
So we classify anemias into microcytic hypochromic, normocytic normochromic, and macrocytic types. Beginning with the microcytic hypochromic anemias, which is when the MCV is under 80 femtoliters. Here, these anemias are due to impaired hemoglobin synthesis. And some examples include the classic iron deficiency anemia and thalassemias, where the globin chain synthesis is defective. We could also see this in anemia of chronic disease in some cases, and that would be due to iron sequestration. Moving on to the normocytic normochromic anemias, where MCV is anywhere between 80 to 100 femtoliters, and these involve either acute blood loss or reduced red blood cell production, without affecting the cell size itself. Some examples to keep in mind include acute hemorrhage, anemia of chronic kidney disease, and aplastic anemia. Last, but certainly not least, we have the macrocytic anemias, MCV being over 100 femtoliters. These result from defective DNA synthesis, leading to large, immature red blood cells. And one more round of examples for you all. We have the megaloblastic anemias caused by a vitamin B12 or folate deficiency, and non-megaloblastic macrocytosis, seen in liver disease and alcoholism.
Okay, that's pretty straightforward. So it's based purely on what the RBCs look like under the microscope. Let's look at another way to classify anemias, the one that explains why it's happening.
That, my dear Shahad, would be the mechanistic classification, which helps us figure out what's going wrong in the production process, the total lifespan of the cells, or the loss of RBCs. We have three big categories to go through: blood loss anemia, hypoproliferative anemias, and hyperproliferative anemias. Starting with blood loss anemias, which include the acute and chronic. Acute blood loss, seen in trauma or surgery, will initially cause a normocytic anemia with elevated reticulocytes as the marrow tries to compensate. Chronic blood loss, on the other hand, would be from GI ulcers or heavy menstruation, which leads to iron deficiency anemia over time. Moving on to hypoproliferative anemias, which is where we see a decreased RBC production. Here, the bone marrow cannot keep up with our demand. Some causes include nutritional deficiencies, like iron deficiency, B12, and folate, chronic diseases or inflammation, renal failure, aplastic anemia, or cancer suppressing the marrow. Hyperproliferative anemias would be when we have an increase in the RBC destruction. These are the hemolytic anemias, where red cells die early but the marrow is hyperactive, trying to compensate. These include hereditary and acquired causes. Hereditary would be like sickle cell, thalassemia, and G6PD deficiency, and acquired would be like autoimmune hemolytic anemia, mechanical destruction like in prosthetic valves, or infections like malaria.
I feel like that's pretty logical. So it's either the RBCs are being lost, not made enough of, or destroyed too early.
And the reticulocyte count is what tells us what side of the equation we're on. A low reticulocyte count will indicate a underproduction problem, a hypoproliferative anemia. A high reticulocyte count would be when the marrow is trying to compensate for loss or destruction, like we would see in blood loss or hemolysis.
And if we know that reticulocytes are essentially immature RBCs or RBC precursors, this all makes complete sense. The only reason the bone marrow would even try to produce so many RBCs, in the case of a high reticulocyte count, is if it noticed that they were being lost or destroyed by the body. And if the reticulocyte count was low, we could assume there's some problem with the bone marrow that's making it unable to keep up with the body's demand.
Exactly. And now that we've got the foundation, we can start exploring some specific types, starting with the most common one worldwide, so common that I bet 1 in 3 of our listeners probably have it: iron deficiency anemia. Alright, so let us begin with our very first case, Ida Cole. She's a 26-year-old woman who comes in complaining of fatigue and dizziness. She says her periods have always been quite heavy, and she often feels short of breath when climbing the stairs. Her roommate, who came with her to the clinic, says she looks paler than usual, and she always struggles when getting mani-pedis due to the shape of her nails and how brittle they are. Finally, her roommate also complains that she keeps munching and crunching on ice very loudly. Her labs show a hemoglobin of 8, MCV of 70, low MCH, high RDW, and a low ferritin level.
Okay, so there's definitely some anemia due to her low hemoglobin, and it's microcytic since the MCV is below 80, and hypochromic because the MCH is low. Putting all those together, we have a microcytic hypochromic anemia with low ferritin. In a woman with heavy menses, this is a classic case of iron deficiency anemia.
Almost too perfectly written.
Iron deficiency anemia happens when iron stores are depleted, and the bone marrow can't make enough hemoglobin. Remember, iron is a key component of heme. So without it, you get smaller, paler RBCs, hence the microcytic hypochromic pattern. So this isn't just a low hemoglobin issue, it's really a problem of defective heme synthesis. Now, let's talk causes. Why do people become iron deficient in the first place?
So we can group them into 4 main mechanisms: decreased intake, decreased absorption, increased loss, or increased requirement. For decreased intake, it essentially means that there is poor dietary iron, which is especially seen in infants, children, vegetarians, and college students, who always eat takeout. Decreased absorption is seen in celiac disease, gastrectomies, or chronic diarrhea, since iron is absorbed in the duodenum. Increased loss is the most common cause in adults. In women, that would be caused by menstrual blood loss, and in men and postmenopausal women, it would be due to GI bleeding from ulcers, polyps, or an underlying colon cancer. And finally, we have increased requirement, which we would see during pregnancy, growth, or chronic illness.
So it's either not enough in, not absorbed enough, lost too much, or needed too much.
Precisely. And globally, the highest prevalence is in children and women of childbearing age, especially in developing countries.
Okay, so once we suspect IDA from our amazingly taken history, what investigations would we carry on to confirm it?
So, considering the fact that we're discussing the blood, I'd assume that we'd be starting with a complete blood count. And we'd also do iron studies. Here's what we'll see. We would see a low hemoglobin, low MCV, and a low MCH, giving us the microcytic hypochromic pattern. We would also see a high RDW, so a lot of size variation in our red blood cells. We would see a low serum ferritin, which is the most sensitive test unless there is inflammation. We would see low serum iron and transferrin saturation, as well as a high total iron binding capacity, since transferrin will rise to search for iron. Finally, we would see a low reticulocyte count, because the marrow will lack the raw materials.
So low ferritin plus high TIBC is a classic IDA signature.
But do remember that ferritin is an acute phase reactant, so in inflammatory states it can be falsely elevated, and that's why we want to look at the full pattern and not just one number.
And clinically, we'd see pallor, fatigue, shortness of breath, and sometimes pica, an appetite for non-food items like clay or ice, exactly like what we saw with our patient Ida Cole. Chronic cases can cause spoon-shaped nails, called cholinikia, and in severe disease, even cardiomegaly or heart failure due to prolonged hypoxia.
So what should we tell our dear Ida when it comes to treatment? Pretty straightforward. You don't have iron, we want iron. We want to treat the underlying cause as well, obviously. Usually we would be giving a oral ferrous sulfate, around 200 milligrams daily, taken on an empty stomach for the best absorption. We would want to continue this therapy for 6 to 9 months after hemoglobin normalizes to replenish our stores. In severe cases or in cases of malabsorption, we would probably use a parenteral iron. And of course, we always want to investigate the source of the bleeding, especially in adults, because chronic GI blood loss may hide something serious like a carcinoma.
Right, always fix the leak before refilling the tank. All right, now it's time for a quiz. Ida comes in a few months later, still with chronic fatigue. She has a hemoglobin of 9, MCV of 70, ferritin of 8, a serum iron of 20, and a TIBC of 420. Ida says that she's heard of a type of anemia that resembles her lab values. Which of the following findings best distinguishes her condition from thalassemia traits? Is it A, low MCHC, B, high RDW, C, low MCV, or D, normal reticulocyte count?
The answer would be B, high RDW. In iron deficiency anemia, there is significant variability in the RBC size due to ongoing defective erythropoiesis, so our RDW will rise. In thalassemia trait, the cells are uniformly small, keeping the RDW quite normal.
I do hope Ida is more compliant with her iron pills. Now that we've nailed iron deficiency anemia, let's move on to another common type, anemia of chronic disease, which can look similar on labs, but comes from a very different mechanism.
So our next patient is Alex Cron, a 60-year-old man with rheumatoid arthritis who complains of persistent fatigue. His labs show a hemoglobin of 10, MCV of 85, low serum iron, low serum total iron binding capacity or TIBC, and a normal to high ferritin level.
So we have normocytic anemia since the MCV is between 80 and 100, low iron, but ferritin isn't low like it was with Ida. Anemia of chronic disease is one of the most common anemias in hospitalized or chronically ill patients, usually mild to moderate and either normocytic or slightly microcytic if it's been going on for a long time.
Little fun fact for you, Shahad, it is also called anemia of inflammation. And it happens when iron is present in the body, but it is unavailable for use. And red cell production is suppressed by the ongoing inflammation, infection, or even the malignancy.
So the iron isn't actually gone, it's just locked away where the marrow can't reach or utilize it.
That is a perfect analogy, Shahad. The marrow is ready to work, but the body keeps the supplies under lock and key.
So how does this even happen?
The main culprit here is hepcidin, which is a small peptide hormone made by the liver. During chronic inflammation, cytokines, especially IL-6, will tell the liver to ramp up hepcidin production, This hepcidin will then do three things. It'll block the ferroportin, which is the iron export channel on macrophages and enterocytes, meaning that iron will not be leaving its storage sites or be absorbed from the intestine. It will suppress erythropoietin, and it will directly inhibit red cell precursors in the bone marrow. So even though the total body iron is normal or sometimes even elevated, the serum iron levels will fall, and red cell production slows down.
So the body's trying to keep iron away from bacteria during inflammation, but ends up starving its own marrow instead.
Very helicopter parent of it. It is a protective mechanism that sometimes will backfire.
So, how would you recognize anemia of chronic disease from the lab results?
So there are a few classic clues that we should keep an eye on. First, low hemoglobin and low serum iron, just like in iron deficiency. Second, low total iron binding capacity, or TIBC, because the liver will reduce transferrin production during inflammation. Normal or high ferritin, since ferritin stores iron inside macrophages, and it also rises as an acute phase reactant. And finally, low reticulocyte count, because the marrow is not being stimulated properly.
So, the pattern is low iron, low TIBC, but ferritin is high, just like what we saw with Alex Cron.
And most patients already have a chronic condition that we can point a finger to, like rheumatoid arthritis, lupus, tuberculosis, chronic infections, kidney disease, or cancers like lymphoma. The anemia tends to be mild and stable, with hemoglobin levels rarely dropping below 9, unless the underlying disease worsens.
And how do we treat this?
So the key to treatment here is to tackle the underlying disorder. If you control inflammation, the anemia will usually improve on its own. But do keep in mind that iron supplements won't be of much help. The iron isn't missing, it's simply trapped. But in select cases, like chronic kidney disease or refractory inflammatory states, we can give recombinant erythropoietin to boost red cell production.
So, there's no point in flooding the system with iron when the body won't even release what it already has. Now, let's test everyone's knowledge. Ida's mom is a 58-year-old woman with systemic lupus, and she presents with fatigue. Her labs show hemoglobin of 10, MCV of 88, serum iron of 25, ferritin of 220, and TIBC is 180. Which of the following best explains her anemia? A. Iron malabsorption due to celiac disease. B. Autoantibody-mediated RBC destruction. C. Hepcidin-induced iron sequestration. Or D. Defective heme synthesis.
You know, Shahad, you gave me a pretty big hint by mentioning lupus. The correct answer here is C. Hepcidin-induced iron sequestration. Chronic inflammation from lupus will increase IL-6, and this will boost hepcidin levels. That will trap the iron in macrophages and decrease EPO activity, producing a low iron, low TIBC, high ferritin pattern.
So the iron is there, just inaccessible.
And that will set the stage for our next big category, macrocytic anemias, where the red cells are actually a little too big for us. We'll start with vitamin B12 deficiency, which is one of the most important causes of megaloblastic anemia. All right, listeners, our next patient is Megan, a 55-year-old woman who comes in complaining of fatigue, tingling in her hands and feet, and a difficulty in walking. On exam, her tongue looks smooth and kind of beefy red, and her labs will show a hemoglobin of 8.2, MCV of 110, and low vitamin B12 levels.
Okay, so this is a macrocytic anemia because the MCV is above 100, and she has neurologic symptoms. This is a typical presentation of B12 deficiency.
Quite the nerve-wracking situation to be in. Megaloblastic anemia refers to a group of anemias caused by defective DNA synthesis, leading to the production of large, immature, and dysfunctional red cells called megaloblasts. When it is due to vitamin B12 deficiency, the problem isn't just in the blood. It can also affect the nervous system.
So basically, the cells grow in size because the nucleus can't divide properly, right?
Exactly. DNA synthesis slows down, but the RNA and protein synthesis will continue normally. The result is a mismatch, large cells with immature nuclei but immature cytoplasm.
All right, let's talk about causes. How do people end up deficient in B12?
So B12 deficiency can happen for several reasons, but we will be grouping them into three big categories: decreased intake, impaired absorption, and increased requirement. Starting with the decreased intake, which is seen in strict vegans who tend to avoid animal products, since B12 is found mainly in meat, eggs, and dairy. impaired absorption, where the most common cause overall is pernicious anemia, an autoimmune condition that destroys parietal cells or intrinsic factor, and it can also be from gastrectomy, ileal resection, Crohn's disease, fish tapeworm infections, or bacterial overgrowth in the small bowel. Last but not least, we have increased requirement, which is a bit rare but can occur in pregnancy or hyperthyroidism.
So the key takeaway is that you either don't eat enough, can't absorb it, or rarely you're using it up too fast.
Exactly. And do remember, B12 absorption requires intrinsic factor from the stomach and an intact terminal ileum. So any problem along that pathway will probably cause a deficiency.
Okay, so what should we look out for clinically and in labs?
So we want to think of pancytopenia and neurological symptoms. Patients will often present with fatigue and pallor from the anemia, glossitis, which is the smooth, beefy red tongue, paresthesias, ataxia, or a loss of proprioception due to the demyelination of the posterior columns and lateral corticospinal tracts of our spinal cord. In our labs, we will see macrocytosis, an MCV over 100, with oval macrocytes and hypersegmented neutrophils on peripheral smear, low serum vitamin B12 levels, given that we are talking about a vitamin B12 deficiency, and elevated methylmalonic acid, or MMA, and homocysteine, both of which build up because B12 is needed to metabolize them.
So high MMA and homocysteine confirm that the deficiency is B12 related.
And if the cause is pernicious anemia, we'll also find anti-intrinsic factor antibodies and anti-parietal cell antibodies, plus elevated gastrin levels from achlorhydria.
Treatment is simple but pretty important. You have low B12, so you want to replace it. This B12 is usually given as an intramuscular injection since oral absorption is often impaired. Patients with pernicious anemia need lifelong B12 therapy. Neurological symptoms may improve if treated early, but if the deficiency is prolonged, the nerve damage can unfortunately become permanent.
Early recognition is pretty important. We can fix the anemia, but not always the neuropathy.
All right, let's test this one. Years later, Ida got a gastric sleeve, and now she presents with fatigue, numbness in her feet, and difficulty walking. Her CBC shows a hemoglobin of 8.5, MCV of 115, and hypersegmented neutrophils. Serum studies reveal low vitamin B12, elevated homocysteine, and elevated methylmalonic acid. Which of the following additional findings is most likely present? A. Low gastrin level. B. Anti-intrinsic factor antibodies. C. Elevated ferritin level. Or D. Normal methylmalonic acid.
So the gastric sleeve is pretty important here. Sometimes after it, a pernicious anemia could occur. So the correct answer here is B, the anti-intrinsic factor antibodies. So pernicious anemia is the most common cause of B12 deficiency. Gastrin levels are usually high, not low, due to a loss of acid-secreting parietal cells.
And the key lab clue is that both homocysteine and MMA are elevated in B12 deficiency.
Exactly. And now, not all megaloblastic anemias involve neurological symptoms. Our next one, folate deficiency, will affect DNA synthesis just like B12, but it spares the nervous system.
All right, Yomna, tell us about Phil.
So Phil from Philly is a 35-year-old man who has been feeling quite tired and weak as of recently. He admits to having a pretty poor diet and heavy alcohol use. On examination, he looks pale and his labs show a hemoglobin of 9, as well as an MCV of 108. Peripheral smear shows microcytosis and hypersegmented neutrophils. His vitamin B12 levels are normal, but his serum folate is pretty low.
A poor diet and an alcoholic with these lab findings? This is another macrocytic anemia, but there's no neurological symptoms and normal B12. That points us toward folate deficiency.
So folate deficiency causes the same type of megaloblastic changes in the bone marrow, but unlike B12 deficiency, it does not affect the nervous system.
Folate, or vitamin B9, is essential for DNA synthesis, especially in the formation of purines and thymidine. When it's deficient, DNA synthesis slows down, leading to impaired nuclear maturation and large, immature megaloblasts in the bone marrow. So, just like with B12 deficiency, the problem is in DNA synthesis, except this one doesn't cause neuropathy. Now, let's talk about the main causes of folate deficiency. Yomna, you want to take this one?
So there are several, and they mostly come down to either not getting enough of it in your diet, not absorbing it well enough, or losing it too fast. beginning with the decreased intake, and this is common in people with poor diet, like with Phil, alcoholics, infants, and even the elderly. Folate is abundant in green leafy vegetables, like spinach, but it is easily destroyed by cooking, so maybe we should tell Phil to add some spinach into his salads and don't cook it. Malabsorption is seen in celiac disease or any jejunal pathology, since folate is absorbed in the proximal small intestine. Increased requirement could occur during pregnancy, infancy, cancer, or chronic hemolysis, basically situations where cell turnover is high. And finally, we have certain medication that can interfere with folate metabolism, such as methotrexate, phenytoin, and some oral contraceptives.
So, alcohol, pregnancy, and anti-folate drugs are the classic culprits.
Exactly, and because folate stores in the body are quite limited, deficiency can develop within weeks to months, unlike B12, which usually takes a few years.
So, if we suspect folate deficiency, what should we look for in labs?
Alright, so here's what you will find. You'd see a macrocytic anemia with oval macrocytes and hypersegmented neutrophils on peripheral smear. You would see a low serum folate level. Obviously, it's a folate deficiency. And you would see a normal vitamin B12 level. Finally, we would also see an elevated homocysteine and a normal methylmalonic acid.
So, the difference is that only homocysteine is elevated here. MMA stays normal.
Yeah, that is the key biochemical distinction between folate and B12 deficiency.
And clinically, we said there are no neurological symptoms, right?
Right. Folate deficiency can cause glossitis, fatigue, and anemia, but thankfully we don't see neuropathy. Treatment is usually with oral folic acid supplementation, usually 1 to 5 milligrams daily. But there is a very critical rule here, Shahad. You always want to rule out vitamin B12 deficiency before giving folate, because giving folate alone can correct the anemia while allowing the neurological damage from B12 deficiency to progress unnoticed.
That is a really important rule, so let me just reiterate it. Never treat a macrocytic anemia blindly with folate without checking B12 first. All right, let's test your recall. Ida's cousin, a 28-year-old pregnant woman, presents with fatigue and pallor. Her CBC shows a hemoglobin of 9.5, an MCV of 110, and hypersegmented neutrophils. Serum vitamin B12 is normal, but folate is 1.8 nanograms per microliter. Which of the following additional findings is most likely in this patient? Is it A, elevated methylmalonic acid and homocysteine, B, elevated homocysteine with normal methylmalonic acid, C, normal homocysteine and methylmalonic acid, or D, neurological deficits due to dorsal column demyelination?
The correct answer is B, elevated homocysteine with normal methylmalonic acid. That pattern is classic for folate deficiency, since B12 is needed for MMA metabolism, but folate isn't.
All right, so now that we've covered all the major types, microcytic, normocytic, and macrocytic, it's time to tie them all together in a quick recap. Yomna, take the lead.
So the best place to start is always going to be the MCV, because this is going to divide our anemias by red cell size: microcytic, normocytic, and macrocytic.
Right. Microcytic anemias have small, pale cells because hemoglobin synthesis is impaired. The main culprits are iron deficiency, thalassemia, and sometimes anemia of chronic disease.
And normocytic anemias have normal-sized cells, but fewer of them. This is where we see things like acute blood loss, renal failure due to low EPO, and chronic inflammatory states.
Then we have macrocytic anemias, which feature large red cells. The megaloblastic ones, B12 and folate deficiencies, are due to defective DNA synthesis, while the non-megaloblastic ones can stem from alcoholism, liver disease, or hypothyroidism.
And that would be the morphological side. Mechanistically, we can sort them into 3 main categories: blood loss, underproduction, and destruction.
Blood loss anemias are straightforward. Acute hemorrhage gives you a normocytic anemia with a high reticulocyte count, while chronic bleeding causes iron deficiency. Underproduction or hypoproliferative anemias include nutritional deficiencies, chronic inflammation, renal failure, and marrow suppression.
And then we have the hyperproliferative or hemolytic anemias, where red blood cells are destroyed early but the bone marrow compensates. Here's where we see sickle cell, thalassemia, G6PD deficiency, and autoimmune hemolytic anemia.
Okay, now that we've got the types out of the way, let's summarize the key lab patterns for the types we discussed today, since that's what shows up on exams.
In iron deficiency anemia, we're going to see a low iron, low ferritin, high TIBC, and high RDW. It is a classic microcytic hypochromic pattern.
Meanwhile, in anemia of chronic disease, we see low iron, low TIBC, but normal or high ferritin because the iron is trapped, not depleted.
And when our MCV shoots high above the hundreds into the stars, think of macrocytic causes. For B12 deficiency, both homocysteine and methylmalonic acid are elevated, and you get neurological symptoms.
While in folate deficiency, only homocysteine is elevated, and there are no neurological findings, just the anemia and sometimes glossitis.
And a quick diagnostic tip, always check the reticulocyte count. A low reticulocyte count suggests a production problem like iron or B12 deficiency, whereas a high one will indicate blood loss or hemolysis.
And never forget, iron deficiency in adults is a diagnosis that needs an explanation. Chronic GI bleeding or malignancy should always be ruled out.
Oh, and also, never give folate without ruling out B12 deficiency. You may fix the anemia, but worsen the neurological damage, and that is very nerve-wracking.
And for every anemia, ask 2 important questions. How big are the red cells? And is the bone marrow keeping up? If you can answer those, you're already halfway to the diagnosis.
Perfectly said, my dear friend. Understanding those 2 questions is what separates memorizing anemias from actually thinking through them.
And that wraps up our episode on anemias. From microcytic iron deficiency to megaloblastic B12 and folate deficiencies.
We've seen how a simple drop in hemoglobin can actually represent very different processes, whether it's loss, underproduction, or premature destruction of the red cells.
And I think that's what makes anemia such a core topic. They show how labs, morphology, and mechanism all come together to tell a story about what's happening inside the body.
Right, it's not just about memorizing values, it is about understanding the logic behind them. When you approach anemias that way, it stops being confusing and actually starts making sense. I really did wish I did that in my first year.
Couldn't agree more. So, whether you're in pathology, internal medicine, or just reviewing for your next exam, remember, start with the MCV, check the reticulocyte count, and think about why the marrow isn't meeting demand. Thank you all for tuning in to PodBites. We hope today's episode helped make anemias a little clearer and a lot more approachable.
Don't forget to follow PodBites for more high-yield, bite-sized discussions on key medical topics, and be sure to have some spinach.
Until next time, stay curious, stay sharp, and keep learning.